Three, two, one. We are live now, sir.
Yeah, this is fantastic. Very good evening to all here. Thanks for all the participants who have joined us today in this fantastic webinar. This is Dr. Shiva from India. On behalf of SK Heart Foundation, I welcome both of our speakers today, Dr. NIL Johnson from USA and Dr. Hazra. Both are very eminent figures in this very field, and particularly Dr. NIL Johnson has done a pioneering work in coronary physiology. We are very, very fortunate to have him here today. And Dr. Hazra, the most impressed guy in recent times for me, in the sense that he is a master of so many trades in coronary, from device to pacing to whatnot. Of course, his main focus is on coronaries. And today we kept the topic acute coronary syndrome, basically complete versus culprit PCI. Culprit only versus complete. For culprit only, we have Dr. Hazra, and for the complete, we have Dr. NIL Johnson. We thought with his pioneering work in physiology, he can guide us where we are edging towards complete, and as on date, the guidelines are more towards culprit. So we thought this debate, not exactly debate, we basically want to evoke more discussion on this so that at the end of this symposium, everybody carries with what required, when, and for why, all that. With this welcome as well as introductory notes, I now request Dr. P.K. Hazra from West Bengal, Kolkata, Amri Institute, the most impressed interventional cardiologist as far as I am concerned, to give his talk on ACS, culprit only. Please, sir.
All right, Shiva, welcome to the debate, Dr. Johnson. Today's talk will be restricted to STEMI and culprit because that is most controversial and debatable in 2020. And there are many issues which have to be covered. Two STEMI ECG may be similar, but not two STEMI patients are similar. And we have a concept of tip of the iceberg for many years in scientific discussions. So once you do the culprit vessels, what you are left with? You are left with ischemia trial-like patients, syntax trial-like patients, complete trial-like patients, and compare acute trial-like patients. I'll give one kind of analogy here that doing a culprit vessel on the day 0 is just like catching a leopard when he's quite active and quite agile. On the other hand, doing a complete index or stage procedure in the setting of acute coronary syndrome and STEMI is just like, Sochi Park, the Putin, the president of Russia, is actually tamed this animal and playing with him. So debate should be redefined, culprit only on day 0, and what's the hurry? It's a matter of one prick, vascular complications of complete devasculations versus 2 pricks complete devasculations. Day 0 versus day 1 to day 45 in complete trial. The debate is angio versus the physiology. The jury is still out. Shock versus non-shock, high syntax versus low syntax, CKD versus non-CKD. A COVID is a new normal situation which was never ever discussed in any scientific trial. And this is very, very important in 2020 onwards. The centers with MCS, the DOT 2 unloading time versus non-DOT 2 unloading time, and without MCS, CTO versus non-CTO coronaries, the definition of significant coronary artery disease into multivessel PCI by angiographic or QCA varies from 50 to 60, 60 to 70, 70 to 80, and 90. When you have a 90% lesion, there is no controversy. There is no debate that it has to be fixed. But the debate comes when you fix 50 to 60% lesion with or without help of FFR. Vulnerable patients, vulnerable plaque, and non-vulnerable patients. What about a debate when you have to face a cold winter call duty versus warm summer daytime culprit versus complete vascular PCI? Culprit, large non-culprit vessel versus non-culprit side branch by angio-FFR. complete, incomplete revascularizations by stent and DEB. When you put a DEB in non-infarct related artery, you do a good job, but it is not to stent and this artery is incomplete revascularized. We do not know this data. Ambiguous infarct related artery, plaque modification when it is required like rota, CSI, go for culprit result only on the day 0. Poor result in infarct related artery versus good result in infarct related artery. There may be a debate, but I'll go for good result in infarct related artery. Then I'll think about completeness. Do not chase 2 millimeter vessels like which has been included in many trials and claim victory that you have gone completely in reducing ischemia and future events. But what we are actually dealing with, we are dealing with such kind of patients, fixing the RCA, inferior MI, whether you need to fix the LAD now, later, FFR now, later, ischemia test now or later, or do nothing, give medical therapy a chance. FFR, IFR, PDP is luxury in many countries. And how many centers in India has the FFR? Many STEMI has collaterals from non-culprit vessels, takes time to disappear, and functional collateral overestimate FFR towards 0. And ad hoc PCI is always harmful in our country. Complex STEMI done by relatively young fellows in our country. So sit back and think for tomorrow. Can get a helping hand from your seniors for decision making. Now there may be 3 strategies on both sides: aggressive, day 0 completeness, or safe play on day 0, go for incomplete revascularization for the day 0 and come back tomorrow. Or take a middle path. When you finish each and everything on the index admission or stage it from day 1 to day 45 based on angioed FFR. I will definitely not recommend to go aggressive and finish everything on day 0. I will recommend either you stage after day 0 from day 1 to day 45, culprit only in day 0 because there are issues of cost effectiveness, contrast nephropathy, unstable conditions, stent thrombosis, potentially doing more stents, unnecessary PCI, and you have a chance for hard cream opportunity to have a discussion, share decision making, and the science is unstable because the jury is still out. You can argue always for cardiovascular death once you come to know the complete star, but what you should do with this kind of lesions where you have to extend your stent to the left vein, you have to have imaging, I will rather go for good sleep after doing the culprit only. And there is a problem in many trials, and these trials sample size is small, number of events is very small except culprit shock. They are dealing with sick patients, and flower AMI has added a new dimension to death AMI revascularization rate. Even that trial was having very small events. So now look at these trials. Look at these trials that male is predominantly in primary culprit dynamic, compare culprit shock, complete 80% and 85% that male predominated people. We have ACS in female, they have a different mechanism, menopause, CAD, etc. Cardiomyopathy, Takashima cardiomyopathy, or COVID cardiomyopathy can come as a surprise. You don't have to do anything on day 0. You may see a normal coronary artery. The follow-up longest with complete by Dr. S. Mehta, Samir Mehta from Canada, 36 months. But other trials, even the flower AMI trial, recently published 2 days ago, is 12-month trial. In India, we do see AMI, but differently at younger age, when you get a lot of single vessel disease, unlike very elderly, very elderly people in primary culprit in Caucasian population, Western or any other country outside Asian territories. So these people in India, we get a lot of multivessel PCI, CTOs, calcification, etc., which may be a difficult proposition to do or finish on the very first day. And you will be surprised, these many trials, they have reported CV death MI benefit, But look at this complete trial. They are dealing with very selective patients, low syntax, 16. And 90% of patients, they did not have any syntax residual. And no shock patients were included, though it was not an exclusion criteria. The flower MI, it's a good trial, but again raised another debate. And they are suggesting to go for visual pathway rather than FFR pathway. Angio-guided is cost saving, is as good as FFR. Now, these are the trials published from 2004 to 2021. Some are indexed, some are staged. And culprit shock, none of them had any indexed or staged completeness. It was done on the day 0 in non-culprit vessels. And what you have learned, that there is a paradox. What you have learned from here, that completeness is the way to go. And suddenly there is a paradox. If the subset is changing from stable to unstable, non-shock to shock, then there is a problem, and you should go for culprit vessel. The culprit only vessel is much more forgiving than completeness. Now, the size of the trial does matter, very large trial, but it has got its own problem. FFR less than 0.8, and you will be surprised, in spite of having knowledge, in spite of having Dr. Johnson in our discussion, the rate of FFR in non-culprit vessel incomplete is just less than 1%, 0.8% to be precise. Angio, more than 70% has taken as criteria. And if you look at other things like compare acute, it's not without problem. All-cause death was increased by 25%. In fracturing, there is no difference in the MACE, rather, non-significantly increased by going completeness. So who is the winner? The winner may be complete here, but again, small trial. It is faulty design in culprit shock. I would say it is a faulty design, but winner is again culprit. Who is the winner in complete? Complete day 1 to day 45, not day 0. Who is the winner in flower MI? Again, angio-based discussion. So, is it so clear that in spite of having so much confusion, complete gives some idea, some new lights? The 1 to 3 days PCI, 31 patient hazard ratio is 0.77. But once you differ from 3 days to 45 days in that cohort, that there is more benefit. So what is the hurry, sir? It is not crystal clear. The path is still confused. So jury is still out in complete trial. 70% on I estimations. They have ignored, or they have very small FFR, as I told you, and randomization was done within 72 hours of culprit vessel PCI. These are already tamed animals, tamed leopard I have shown. 1 to 45 days is arbitrary. There is no nationally, there is no rationally, there is no difference in stroke, but cardiovascular death, repeat revascularization is the winner in all these trials. Less infarction, but there is no difference in all-cause mortality. This is publication 2020, not very long ago. Because if you go for FFR, there is a problem in initial phase. There is increment of the FFR, and it goes down. So flower CMI this month has killed FFR. And what it has killed? It has killed the concept of stable coronary artery syndrome in non-STEMI patients, fame, dynamic, primality, and compare. There is decreased incidence of events and CV death and CV death MR. And again, Gregstone has killed the FFR in ischemia trial, which has been discussed just 2 days ago. What he has mentioned, that if you go by anatomic complete revasculations, there is a benefit even in ischemia trial. Though we are not dealing with acute situations, but we are actually confessing the concepts or expressing the concern of FFR. And if you go by FFR, complete revasculation, there is no benefit even in ischemia trial patients. So go by angio. So what completeness means in 2021? Post PCI IFR more than 0.95, MSA on imaging, TV4 on TV grade 4, good IMR, good CFR, no vulnerable plaque left behind at the cost of metal jacket. There is a problem in the complete trial, because once you have seen the angio, the operator knows when to take these patients for multivessel PCI. So again, there is a problem. So one trial cannot give us complete directions. The timing was again biased. As I mentioned, the trial was not powered to find significant differences in the subgroups within the non-culprit vessel PCI status. Despite this, nominally significant benefit was found for both co-primary outcomes in patients stratified to both in-hospital and after discharge non-culprit vessel PCI. Now, there is a problem of composite endpoints, death, myocardial infarction and stroke and revasculations. So what this revasculation refractory engine is doing here, actually eating away the mess. Actually, these are having huge weight on the mess. This is not the death or MI, but mainly contributed by the revascularization, repeat revasculations. Culprit shock again mix of STEMI and non-STEMI, all forms of acute coronary syndrome. No angiographic covariates other than TIMI grade. Microcirculation is an issue. 25% images could not be analyzed. Incomplete revascular unless flow-limiting non-culprit vessels supplying large area myocardium, unclear culprit, multiple culprit, do not go for complete revasculation in the shock patients. ESC guideline, class C for routine revasculation non-complete vessels. We do not chase 2 millimeter vessel. So this is explored CTO. In CTO situation, you do not go for completeness, go for culprit plus. That means you can have some idea of the non-culprit vessel by PDPA, QFR, wireless, and with wire, FFR and IFR. But after flower MI, there is a question. Saline contrast in OCT, Iverson contrast OCT in lab. Be prepared for next sitting. Know the patient better. Know the non-culprit vessel better. Give patient a right of shared decision making next morning. What is the hurry? And why not day zero completeness? Because the cost, contrast, lack of confidence, counseling lacking, clear guideline lacking, the clock, the catastrophic. You do not get all these anesthetist, a surgeon in the middle of the night, complex anatomy CTO, and confusing stenosis sometimes, and COVIDity. The guideline is still not clear. European staying at 2A, they're much more aggressive. But look at the Americans, still 2B in spite of having all these trials. So ladies and gentlemen, let me finish. Tomorrow is just another day, another PCI. Today is a day for culprit and culprit plus only. Day zero multivessel PCI beyond culprit should be very selective and easygoing. Day zero multivessel PCI in shock, definitely not. Functional complete revasculation and give modern medical therapy a chance. Wait for comorbidity reports to come, including COVID. Review and discuss with your friends and colleagues and your boss. Guidelines are not class 1 or class A, so no medical legal issues. Stay cool, sleep well, come back tomorrow. And I have not seen anybody to survive if any side branch, male vessel in non-culprit domain closes during heroic complete multivessel PCR in more than 5,000 real life patients. So today is just tomorrow's yesterday. Heaven is not going to fall. Doing a non-culprit complete revasculation PCI tomorrow or day after. So patient is important. Everybody is important. Go for a hearty discussion next morning. So do culprit today, complete tomorrow. 2 to tango, friendship. No to rivalry. World is one. So is the patient. Thank you.
This is absolutely fantastic, as usual, as expected from Dr. Hazra. He has taken this debate really in a broader perspective, even though trials like PRAMI, Complete, Danami, CVL-PRIT were in favor of complete revascularization, if not during index PCI, ranging from anywhere, ranging from any time after fixing the culprit PCI. The clear message here is the completeness that's expected out of the culprit vessel, and there is definitely another day to look into the non-culprit vessels. The completeness of the culprit vessel in terms of looking into vulnerable block in other areas, the culprit of the culprit. We are now talking about the non-culprits. We are just fixing only the culprit. There are culprits beyond the so-called culprit of the culprit we need to know. So basically, we are here. The basic idea behind this passion of completeness is we need to, this is not basically a debate. We need to get a message out of why there is a movement of entire this interventional community towards completeness of revascularization or near complete revascularization. It is basically because of one reason, that maze-free survival, either out of the culprit vessel or out of the non-culprit vessel. That is the one particular reason this entire community is, it is not because of the passion, not because of guidelines, not because of the, we, at the end of the day, we want to have a patient who should have a maze-free survival. The maze event should not happen either from the culprit vessel or not from the non-culprit vessel too. With this, I invite Dr. NIL Johnson, how he is going to debate his friend Dr. Hazra from culprit only today. There is yet another day. Even though the passion is for completeness, there are logistics, limitations, which all he talked about. Let's invite Dr. NIL Johnson with his pioneering work. Let's see how he is going to take us in this. Please, sir.
All right, thank you so much for the opportunity to speak. Good morning, everybody from Texas. We actually had a loose tiger here in the city just last week that the police had to track down. So it's not only there that it happens. These are my disclosures, nothing specifically related to this talk. And I wanted to start off with a case. In fact, I think you might have seen a slide from it already. This was a 63-year-old man whom I took care of. And you can see his presenting EKG. This had been accompanied by chest pressure for several hours and was nauseous. All of our cath labs were full when he arrived in the emergency department, and so he needed to briefly stop there. He had an episode of ventricular fibrillation, and then he had one again while we were getting him on the table. This is the Emergent Angiogram, and I'll give you my initial thoughts when I saw it. I said, well, okay, the RCA, that matches up with what I see on the ECG. That's obviously the culprit here. But what should we do with this LAD? And so I went ahead and treated his RCA. He was quite nauseous during the case and so was not able to take oral dual antiplatelet therapy. So I had to give a cangrelor until he was able to take that later in the CCU. And he had more VT, and so we gave him some amiodarone, and eventually that quieted down. And so I think you've seen this slide previously, but the question is what to do with these non-culprits. And you see the choices on the slide, and I've seen all of these options done by various people around the world as I've gone around and presented this case and asked polled audiences, what would you do? And I'm sure even within a single country or perhaps even within a single hospital, you would have operators who would make different decisions about which one of these things should we do. And the reason that happens, and this was highlighted earlier as well, is that the guidelines have been fairly lukewarm about what we should do with the non-culprits. I'm showing you here on the top row NSTEMIs, on the bottom row STEMIs, on the left-hand side Europe, on the right-hand side the United States. And you can see that the language is very modest. It says, well, we don't have a lot of randomized trials. Maybe it's reasonable. There's a lot of variability, but the criteria are something that we're still trying to figure out. So the guidelines don't push us in a strong direction, and the reason for that is the data behind it. But fortunately, we've got a lot of new information over the last couple of years, and so I'd like to give you my own perspective on some of the studies that you've just heard about. The COMPLETE trial was a trial that was looking at non-culprits that were noticed at the time of stemming. Has been brought up, although FFR was one of the criteria in this trial, it was really an angiographic trial. Only a tiny number of lesions were evaluated with fractional flow reserve. It was a big trial, a mega trial, over 4,000 subjects, and it was, as mentioned, a trial with longer term follow-up, on average about 3 years. And so you can see in the kind of figure one, if you will, that the incidence of cardiovascular death and myocardial infarction was reduced by complete revascularization. But you'll notice that this effect is a very gradual one. And I think that highlights something that Dr. Hazra brought up as well, and that's that whatever we're dealing with here, it's a benefit that happens over a very long period of time. It's not something that just happens over a day or 2 days or even the first week. You'll notice that those curves take a long time to drift apart from each other. So I think that's an important message just from the duration, the timing of the benefit. The second is to really drill down and ask what was driving this effect. You've heard about these issues with composite endpoints, and that's something that I'll talk about more about in the rebuttal. And really, when you look at death, you can see that there was no significant difference, despite this being a 4,000 patient trial of individuals who presented with STEMI, so a high-risk population. The second is that myocardial infarction was significantly reduced. So really, yes, it was a composite endpoint, but really it was completely driven by myocardial infarction. And when you look at what kind of lesions were driving that, of all the various subgroups, the only one that had a significant interaction was the angiographic severity. So they sent these then, operators reported their angiographic severity, and then they were also sent to a core lab for evaluation. And if you look at the lesions that were 80% visual or 60% by QCA in the core lab, so fairly severe stenoses, that's where all of the benefit was localized. You can see when those criteria weren't present that there wasn't any benefit between a culprit only versus a complete revascularization. And so this has caused several patients or people to ask the question that, well, likely those lesions would have been FFR positive. So what would have happened in this trial had we used FFR instead of an angiographic guided strategy? And so I want to shift a little bit now and talk about what we know about FFR for treating ACS patients. And again, I'll start off with the guidelines, which are very modest. Again, top row NSTEMI, bottom row STEMI, Europe, the United States. Sometimes it's not even mentioned at all in the guidelines, like in the United States NSTEMI from 2014. You can see there's very weak language here: evaluated infrequently, not properly addressed. You know, what should we do about it, right? The guidelines don't push us in a strong direction. What we have learned is that in general, measuring FFR using a medication like IV adenosine is quite safe in ACS patients. This is an overview of 4 different trials looking at very serious things, right? How often can you make a successful FFR measurement? In general, well over 95% of the time, almost all of the time. How often do wire-related injuries happen? Not very often, and probably if you were even going to do angiographic guided PCI, you'd need to put a wire down as well, and rare wire injuries happen there too. And then, of course, there's some rare issues with adenosine, largely related to conduction abnormalities. There's some mild hypotension, but no serious adenosine-related MACE. So it's safe to give IV adenosine. Interestingly enough, if you have concerns about IV adenosine, IC adenosine was even explored in the more distant past as a treatment for reducing reperfusion injury for acute myocardial infarctions. And so it's a relatively well-studied therapy. You can see that this figure brings together 1,000 patients from many different trials looking at IC adenosine versus placebo. And again, no differences in bad things like chest pain or bradycardia or VTVF. Again, you have some higher rates of AV block, but you can give hyperemia either with IV or IC adenosine in a very safe, controlled way, even in patients who have acute coronary syndromes or specifically STEMIs. The second piece that we've learned over the last decade or so is that FFR is reasonably stable in non-culprit. So you don't want to make a measurement in the culprit artery, as Dr. Hazra was explaining. There are dynamic changes in the microcirculation there, so you don't want to do that. But this is a summary of 3 different human studies with about 200 STEMI patients, and then down at the bottom, an animal model looking at kind of a microsphere embolization. And the basic message, if you look at FFR that's measured in the non-culprit vessel on the day of the infarct, and you compare it with the FFR that's measured later, a few weeks or maybe even a month later, you can see that those values on average don't change by very much. In 2 of the 3 studies, they didn't change at all on average. On one of them, it changed by 0.02, so a very small amount. And again, down at the bottom in the animal model, you can see that the FFR in the one that's the non-culprit is quite stable despite serial embolizations. And so what that means is that if you make an FFR measurement on the day of, that FFR is not going to really change very much down the road. And so this brings us to the Flower MI trial, which just came out a few days ago, as was mentioned at ACC. It was a late breaker published online in the New England Journal. And this was a trial that in many ways, I think, drew on fame. Can we compare an FFR-guided strategy to an angiography-guided strategy, looking at non-culprit lesions that were noticed at the time of STEMI? The angiographic-guided strategy was pretty typical, 50% diameter stenosis, whatever that means, and the FFR-guided strategy as well was fairly typical. Here we have, I think, two important differences. The first, it was a more modest trial with a shorter length of follow-up has been mentioned. So just 1 year instead of more like 3, just a little over 1,000 subjects instead of 4,000 subjects. So that makes it a more modest set of data. And then also the outcome was death, MI, and urgent PCI instead of looking at each endpoint individually or thinking about just MIs. I would highlight a few things from their table 2. This is comparing the two different groups. The first thing to notice is that there were many more non-culprit lesions that were evaluated in the FFR guided group. You can see it's about 10% more. And what that tells me, at least anyway, is that operators are much more willing to use FFR to evaluate a lesion rather than just put a stent in it. So even in the setting of a randomized trial, when people were put into the FFR group, it appears as if operators said, well, you know what, I'm not so certain about that RCA. How about we call that a non-culprit and I'll go measure it, as opposed to just stenting it, which is what happened in the other group. The second is highlighted in red down at the bottom, is that just over half of lesions had a positive FFR value. In fact, if you do the number that were treated with PCI, it's about a 40% reduction. And what that means is that an FFR-guided strategy is going to avoid PCI in certain lesions, ones that have a negative FFR values, which will depend upon a range of factors, but in this particular study was about 40% or something like that. The second piece is that even in this large randomized trial, it was interesting to me that 16% of the PCI was done without FFR in the FFR guided group. You can see the missing data here was not present in about 150 of the 1,000 or so non-culprit lesions. And so that rate of why operators would say, hey, listen, I can't measure the FFR in this lesion, it certainly wasn't a wire-related issue, is an interesting one to think about logistically. I would actually turn the flower results around a little bit and emphasize that there's no real penalty for doing less PCI as guided by FFR. You can see in this table that's looking at a variety of endpoints related to functional status, number of anti-anginal medications, quality of life scores, patients with class 2 or greater angina. And you can see that there was no difference in any of those over the next year between the two groups. And so what that tells me, at least anyway, is that FFR is a safe way to reduce your stents by at least a third, if not 40%, and you don't pay a penalty for that. There's no difference in death, no difference in MI, there's no difference in late PCI, and there's no difference in patient-related symptoms. And so that can be a cost-effective thing, of course. It depends upon your geography. But if you are thinking about, well, all right, you have to buy FFR wires for everybody and you get rid of 30 or 40% of the stents, then that means that the FFR wires should cost about 2/3 or so the cost of a stent. And if that happens in your geography, then actually you'll save money using this strategy and you won't have any differences in patient outcomes. So let me come back to this case that I started off with. As you will recall, it was an RCA STEMI with a non-culprit LAD, had a pretty aggressive GI reaction, and so needed IV Cangrelor for a period of time and got shocked a few times for VF. Everything kind of calmed down after the PCI, and his ST segments got a lot better. And it comes back to this question of when do you evaluate the non-culprit? And I think that Dr. Hazra brought up many fantastic points about the timing, and I'll just add one to those that was actually published in the New England Journal as part of the Compare Acute trial, and that's that you can get yourself into trouble sometimes. You can see in one patient the FFR wire caused a dissection in the non-infarct related artery, and that led to a very dramatic outcome. Of course, quite rare. We do a lot of these procedures, and I'd have to say that this happens extremely rarely. But the question is, when do you want to do this? And I think that that's something that can be quite individualized. In this particular patient's case, I brought him back about a month later or so. You can see the RCA and the EKGs right before the primary PCI, right afterwards, and then 1 month later during follow-up, it looked quite good as well. I did FFR on this LAD, and you can see despite having the appearance of a focal lesion, the FFR value of 0.81, when you do the pullback, there was no focal jump over it. In other words, this LAD is really diffusely diseased with cholesterol. There's not one single easy place that you could just drop a stent. And besides, the FFR is greater than 0.8 anyway. And so all of those things for me signified that this really needed medical therapy, and that's what I did. He was actually just seen in clinic last month and has been doing quite well now, almost 2 years out from this treatment, has had no angina or no further clinical events. And so I'd like to conclude with this table. Again, it's a way of thinking about the non-culprit from a physiologic perspective. That is, when should we do it? And I mentioned you don't want to use physiology for clear culprits for the reason that the microcirculation just can't vasodilate. But I've been showing you the data in this presentation, not just for studies like COMPLETE, but also FLOWER MI and some of the paired information on FFRs, hoping to show you that in non-culprits, both NSTEMI as well as STEMI, that FFR is a safe tool, it's a reliable tool, the values don't change. You can certainly get rid of about 30 or 40% of PCI that's unnecessary, and you'll have equivocal clinical outcomes during follow-up. And so I would say that those are some simple takeaways for when it's reasonable to use FFR for looking at these non-culprit lesions in ACS patients. Thank you so much.
I think this is perfect. In spite of Dr. Hazra came up with the FLOWER MI, where it came in support of angiogated PCI. We know that we were comfortable with that statement, but still, FFR is not a bad tool because the intention was to defer the stent. We all know that the ill side of stenting and dual antiplatelets, taking it beyond a year and bleeding propensity, stroke, all those issues were there. Well, with this, I think we can invite Hazra sir back. He has defended, still Dr. NIL Johnson has defended, it's still a safer tool, worthy tool. The intention was not to put a stent. And even those deferrals, there were no great events. That's another interesting point. Effort-based deferrals didn't invite much events. But the problem with both angio-guided PCI as well as FFR-guided PCI is, are we really evaluating the vulnerable blocks? That is one area which is still a gray area. With this thought process, I invite Hazra back with the rebuttal. Again, Dr. Johnson will come back.
I congratulate Dr. Johnson for excellent talk. And look, there is no controversy that completeness should be the goal. Now, in these trials, there is no definition of what is the completeness of the complete trial. Like as I said, whether you do it with IFR, the final, like this is some new GPS PCI, something like this, it's a IFR co-registration with the IFR value more than 0.95, 90% MSA, no vulnerable plaque left. So there is new dimension for the completeness definition 2021. Second, FFR is not bad, but why in some patients it is bad to do complete revascularization that we have learned from ischemia trial. So many of these patients actually combinations of, suppose somebody has 2 vessel or 3 vessel disease in the past, now he's got acute ST elevation, the RCA, we do not know whether this is basically ischemia trial patients converted into acute coronary syndrome, and he goes back to ischemia trial patient again once you fix the right coronary artery. So ischemia trial patients do better on good medical therapy. I'm not saying that if you have 99% LAD lesion, flow limiting lesion, it has to be fixed. There is no doubt about that. If it is left pen, has to be fixed. If it is a proximal LAD-C2, has to be fixed. With a large area of myocardium and jeopardy, I do not agree the ischemia trial has answered that with LV dysfunction. So what I'm saying that FFR in FLOWER AMI is actually neither a loser, so there is no harm of doing FFR. But look at the mean value of FFR in FLOWER AMI trial, 0.79. So something is just 0.1 lesser than the cutoff. That means there are some patients who had FFR more than 0.8, maybe 0.8 to 0.85, 0.85 to 0.9. So if you go in this group of people, if your mean is 0.79, that means you have just ignored the FFR and you have put the stent in them. And then you are saying that angiography is as good as FFR, or FFR is not a bad idea. So what I'm saying, there is one patient, as one treatment is absolutely applicable to one particular patient. So there cannot be a different kind of appropriate patient for one particular patient. May be appropriate for different kind of patients, but may not be applicable to one particular type of patient. So what I'm saying, each patient is different. Completeness should be the goal. The definition of criteria of appropriate criteria for completeness is changing very fast. Imaging should be there. Physiology should be there. The cutoff value of FFR is a problem. If you keep the cutoff value at 0.75, some of the trials perhaps will do better, not at 0.8 in acute setting, because you have microvascular dysfunction, edema, so you have less myocardium. That means your FFR is on the higher side. And once you recover, your FFR goes to the lower side because there is a recovery. So in essence, in summary, completeness should be there. So today you go for culprit. There is another day tomorrow. You can complete. You can have more gadgets in your lab and complete the procedure and try to achieve completely complete revascularization. Over to you, sir.
Perfect, Dr. Johnson. Completeness. If not today, I will aim for a near future. That's a statement from the hazra. Having accepted, is still a useful tool. Which tool, in what perspective, cutoff? We need to rethink about these tools, physiological tools. Sir, please.
Thanks. And what I wanted to do is focus on something that Dr. Hazra brought up that is, I think, really important for these trials, and that's that they're different endpoints, and we should always think about what our goal is when we do these procedures. You know, if you ask, well, did we ever think that we'd be able to reduce death? Certainly not non-cardiovascular death. Stents can't cure cancer or something like that. There has been, I think, over the last several years, a question about could we reduce cardiovascular death? Can we reduce spontaneous MI? The peri-procedural MI story is complex. That's something that, as was mentioned, we certainly can cause injury. PCI is not without cost. It's interesting that it still remains controversial about how to define it. And then there is the issue of angina, and every single trial, including Orbita, and all of them have really shown that that's something that we can improve with PCI. I wanted to emphasize that when you bring an enormous amount of data together, I think there's actually a very simple message. And what we did several years ago is we put FAME2 together with Promulti with CompareAcute. We actually got the patient level data and put it together as one study. And that showed that there is a reduction when you do PCI versus medical therapy. And again, it's one that shows up over many years, but nevertheless, you can see that there's this reduction present, completely driven by the rate of myocardial infarction. In this particular trial, a 5% reduction in absolute rates of spontaneous myocardial infarction over a 3 to 5 year period. And what was interesting when you looked at the kind of patients who came in, because some were FAME2 patients who were stable and some were ACS patients from CompareAcute and Promulti, is that the clinical presentation didn't matter. And what that taught me, I think, is that ACS lesions that are non-culprits, those are actually stable lesions. And so we need to think about them just as we would a stable lesion in a patient who, say, shows up to our clinic with symptoms or has had a positive non-invasive test or something like that. Non-culprit lesions in ACS are stable lesions. What we've learned from, as you can see, over 11,000 patients in all 5 of these randomized trials is that we can't affect death. That's, I think, a fascinating lesson in and of itself. We can reduce infarcts, so stenting does prevent myocardial infarction, 30% relative risk reduction. And it's not just the relative risk reduction important, it's actually the absolute number that's what drives the number needed to treat. And you can see that it's somewhere between 20 and 40. It depends a little bit on how long your follow-up is. But again, it emphasizes this point that Dr. I think Hazra was mentioning too, that it's not just, you have to do it all on the 2 a.m. in the morning when you're doing the STEMI. These are benefits that happen over many, many years. And so you've got time to think about it. Angina is always better, no matter how the trials defined it. And they all had various ways of doing it. We can certainly make patients feel better. And there is some risk, quite modest. You can see these slight rates that are higher for peri-procedural MI, but not too much higher. And so my takeaways are the non-culprit is a chance to think through what exactly you want to do by having PCI in addition to medical therapy. We can't touch death. Certainly we can't cure infections with stents, but what's interesting is we also can't reduce cardiovascular death. We can reduce infarcts by about 30%, number needed to treat, as I mentioned. Peri-procedural MI is complex. It's controversial. It's almost like a whole other talk in itself, but it's not as bad as spontaneous MI. It's not as a dramatic a thing. And certainly with symptoms, we can make people feel better, and that's happened in every single trial. And so when I see a non-culprit lesion, what I do is I first treat the culprit, that's obvious, and then I hit the pause button and I think about, am I going to do this right now? And what are my goals of treatment for it? Is it a spontaneous MI thing? Is it symptoms? What exactly am I doing with it? With the realization that whatever the benefit is happens over years. It's not just something that's going to happen by the next day or even by the time of hospital discharge.
I think I was winning the debate till Johnson presented a rebut, and I accept my defeat. It was fantastic last part.
I mean, I think we're saying a lot of the same stuff, and that's that. I think that this message that you have to do it all at 2 in the morning for the non-culprits, that the data has overwhelmingly convinced me that that's not what we should be doing, and it's an opportunity to think about how to treat these stable lesions, and you don't need to do it at 2 in the morning.
Yeah. So in the last lap, you have defeated me, and the winners takes it all. It was fantastic. Thank you.
But by no means, thanks for the discussion.
I think this is absolutely fantastic. The final rebuttals were excellent, particularly having made sure, that's what Hazra was talking about. It is the culprit, how you are taken care of, you were the very procedural, even from day 1 to coming days. Then the question of individual patients, coronary artery disease, particularly acute coronary syndrome, is a big spectrum. That's why it's interesting even today. Same ECG, same pain, but the way the coronary behaves to the operator is different. So the great suggestion by Dr. NIL Johnson that assess the potency of spontaneous MI from the left out lesions, whether it is from the culprit or from the non-culprit, and take a gear from that. That's the message here. I think if there is from tech guys, any question related to the debate from the audience? We had somewhere around 100 plus audience throughout. When both of you had a debate, if we can invite some questions on that. If not much, I can move on to my lecture, how one can manage thrombus. It's a great privilege for me to make my presentation in front of two giants here. Palniappan, Samir, anything related to the debate? Any interesting questions? Into the questions, is it a hyperemic index which you follow in non-culprit versus assessment, or is a resting index which you often do, Dr. Johnson?
I think we do stress testing for a reason in cardiology. Patients have symptoms when they're active, and we've all seen many cases where the ECG looks normal before they get on the treadmill, and then when they exercise, that's when the EKG happens, that's when the angina happens. And so making measurements at rest doesn't mimic that as well as hyperemic drugs. And you might say, well, okay, adenosine's not 100% physiologic, and that's true, but hyperemic conditions are much more similar to the types of things that happen, I think, to patients when they're undergoing stresses in daily life. And, the coronaries have an amazing ability to auto-regulate and to adapt. And so it's I think, profound to realize that there are really large resting gradients that can be there with absolutely no symptoms, meaning that because of auto-regulation, those aren't causing ischemia. It's only under stress conditions that we unmask that.
There is an interesting question to both of you. There is a trope negative ACS. Will you still go by angio-guided PCI or physiology-guided? Trope negative ACS.
Yeah, if the question is to me, I think trope negative ACS, you have to repeat the trope. Either it is too early or a too small amount of myocardium is involved, so myocardial necrosis is very small. The essence of doing non-culprit complete revascularization is not death, as Johnson has rightly mentioned. Perhaps we are reducing future acute coronary event in the non-culprit vessels. So if you have obvious 90%, 99% lesions in the proximal LED. Whatever may be the trial in this world, go and fix it. Nobody will criticize you. Suppose it is 99% in diagonal, mid-diagonal, OM1. When JNH score is very low, or the diagonal is not supplying more than 10% of the myocardium, whatever you do in this world, people will criticize until unless your troponin is high, patient is unstable. So in essence, if the troponin is small, see, a troponin anemia should be re-evaluated after some time. That's how I can answer this question. Over to you.
This is perfect. Dear Johnson, there's a question for you. There is an atypical chest pain, non-diagnostic ECG, troponin positive, intermediate lesion, single result disease, LAD, proxima. How will you proceed further?
Right. The first point of my kind of thinking is if this is an ACS, to try to find the culprit. Sometimes it's very easy. STEMIs, it's usually very easy. Sometimes it's not so clear. And in cases where it's not so clear, that's where I try to use all of the available clinical data, looking at the EKG, looking at the plaque appearance on the angiogram, doing an echo or an LV-gram to try to understand if there's a wall motion abnormality. And if I feel based on all of that data that there's a clear culprit, I just go ahead and treat it with PCI. Even sometimes after those things, I'm not certain what's going on. You'll get cases that are very unclear. You don't have all of the data, and none of those pieces that I mentioned really gives a 100% answer. And for those ones, I use FFR to try to figure things out. I think if you have the only cases where FFR is really going to be dramatically falsely high and you'll make a mistake is when you have a huge STEMI and you just have got lots of myonecrosis and the myocardium can't vasodilate. But that's not the scenario that I would use it in. It's those ones where even after thoughtfully putting together all of the clinical data, I'm still uncertain if there is a coronary culprit. Then I fall back on making pressure measurements to try to understand, is there something in the epicardial vessels that we can treat, or should we look somewhere else? As you know, sometimes it's a pulmonary embolism or myocarditis, especially with COVID these days. And so FFR negative then leads you down a different route of thinking to focus on other reasons for why there might be enzymes.
That's interesting. So we involve quite a young population in our geography. This is a smoker, male, less than 40 years. It is basically not a great atherosclerotic. It is basically a thrombotic, thrombo-occlusive disease rather than atherosclerotic obstructive CAD. In those scenarios, positive intermediate lesion, will you take a help of imaging as a whole lot of idea of assessing the vulnerable plaque rather than assessment of obstructive element? We know that angina-free life is definitely addressed by a good angio-guided PCI as well FR-guided PCI. But definitely vulnerable plaque gets missed, particularly in this kind of people, young people, more of an atherothrombotic rather than occlusive CAD. Will you do OCT or high definition IVUS, if not for the stent, at least for prognosticate the lesion?
It's a great question. I use a lot of imaging for PCI stuff. I would say in that particular case, I would in general say that negative FFR shows you that there's not much vulnerable plaque. It's interesting. People have done a bunch of cross-sectional studies where they've done CTA and FFR, IVUS and FFR, OCT and FFR. And what you see is when there are vulnerable plaque features anatomically by any of those imaging tests, then the FFR tends to be lower. And when lesions lack those vulnerable features by imaging tests, in general, FFRs are higher. And in fact, one of the reasons that FFR negative lesions do so well is that there's not much vulnerable features or plaque burden underneath them.
Yeah, this is interesting. So you said that you mean that FFR picks up the vulnerability as well.
If I put my 2 cents here, in complete trial, there are OCT sub-studies, and you have to have those kind of vulnerable features in the non-culprit vessels. So culprit, non-culprit vessels, you have to identify in imaging, there is no denial of the fact that good imaging can identify a vulnerable plaque with ruptures, with the plaque burden more than 70%, small MLA, and these are the things. It may be in the future you have to try in large randomized clinical trial, and you have to show that it does translate into clinical as well as cardiovascular death benefit and all-cause mortality. All-cause mortality has never ever changed. You may fix the non-culprit vessel, whether STEMI or non-STEMI. He may die due to renal failure due to your contrast or due to some other things. So all-cause mortality is not going to change. Clinical events are going to change. Repeat revascularization are going to change by fixing this vulnerable plaque. So vulnerable plaque should be assessed when the patient is there in your table. Just a matter of opening another device. The cost is a concern, but it should be practiced. A modern physiology, modern anatomic identifications of patients and their vessels is heading towards imaging. There is no denial of the fact that good imaging saves many patients from unnecessary PCI or a very effective, complete PCI to prevent future events like DAPT issues, stent thrombosis, repeat revascularizations, ISR, etc., etc. Thank you.
This is excellent. This is COVID time. This is vaccine time. Government of India keeps changing the time interval between the first dose to second dose. Started with 4 weeks, 6 weeks, 8 weeks, 12 weeks. Now it is, I think, 18 weeks or maximum 90 days. So there is a question here. Having said that non-culprit vessel is significant, whether it is by angio or by physiology, what is the maximum delay? Where this philosophy ends, non-culprit in a culprit situation. What is the time duration?
To whom?
To fix the non-culprit after the index PCI.
Directed to me. So there are data up to 45 days incomplete. I think in PRAMI or PRAMI, I think it is 56.7 days. And so there's some trial, less than 3 days, less than 2 days, something like that.
Okay. For C2, they took as high as
45 days.
3 months. 45 days? Okay. So is any insight from you, sir, Johnson, sir? How long you can stretch it?
Like, let's say you look at the data from FAME2, compare acute and PROMULTI, the pooled data, and you compare FFR guided PCI to medical therapy. The excess rate of MI over 5 years was about 5 or 6%. That means that every year it's only 1 or 2% of these patients who are going to have a spontaneous MI that you could have prevented with PCI. So, any single day, the risk is very, very small. And those curves take a long time to grow apart. And so some of these things about 30 days, 60 days, it's all a continuum. And what I do practically when I see the patient is to try to figure out a few things. Do I think they're going to be able to come back?
Right.
Is there a profound reason to do it now? Is there some kind of symptom or electrical problem that's going on? Try to get a sense for how compliant they're going to be with medications. I look at the insurance situation as well, which is important in our country. I put all of that data together to try to make a decision and talk with them about options. And if I think there's a great reason to do it in the hospital, I'll do it in the hospital. For example, last week, there was a patient who was a prisoner and it was in jail and had a STEMI and came to our hospital. There's no easy way to get him back for a clinic visit in 1 month. So I just did it in the hospital as part of it. So I think that's where we all put on our doctor hats and our practical hats and make an individual decision case by case, realizing that we don't have to do it the very same moment we do the STEMI. We can wait a little bit to make the best decision.
I think this is fantastic. There are a lot of practical ways to fix the non-culprit. There's a fantastic way out. I think it's 8 o'clock now. Let me quickly take you on my lecture, keynote lecture on how one can manage thrombus. As I said earlier, it's a prestigious moment for me to present this in front of 2 giants here. Let me share my screen. Dr. Hazra, I hope I'm seen and I'm audible. Yeah. Perfect. So I basically kept it as thrombus management in STEMI acute coronary syndrome. My whole lot of discussion is applicable only to STEMI, and I'm going to take this on various perspectives like pathology of thrombus, factors favoring the huge thrombus burden, how can one quantify the thrombi, angiographic predictors of a huge thrombus burden, and pharmacological way to manage it, devices, staging strategy, intracoronary lytics. We all know that this particular syndrome, STEMI syndrome, is a totally occlusive thrombus. Predominantly, it's a red clot, particularly when it comes out of a plaque rupture, which is a dominant case. Another 25% of the time, it could be plaque erosion. When it is plaque rupture, it is mostly rupture around a thin fibrous cap on the backdrop of a large lipid core, or it could be a collagen-poor fibrous cap. There could be vulnerability in the form of macrophages, clotras, crystals. Basically, it is a red clot, organized clot, fibrin-rich clot, deeply adherent to the vessel wall. Whereas the one which arises out of plaque erosion, unlike it is a near normal vessel, there is no much plaque burden. There is more of inflammatory cells recruitment like neutrophils and many smooth muscle cells, and there is a proteoglycan and glycosylglycan rich. It is mostly white clot, platelet rich clot. There is another group, 10%, which happens in elderly CKD patients, the calcific nodule. There was one time there is a sharing of slide by Dr. Hazra in a calcific nodule, particularly in RCA. At the culprit of the calcific nodule, you see a necrotic calcium, whereas at the landings of the stent across the nodule, you have a very stable calcific plaque. So this is different scenarios happens with the STEMI syndrome. And if you look at the factors, it could be patient-related like hyperglycemia, smoking, which we had talked about earlier, vasculitis, could be from lesion-related, which I talked about, plaque rupture, and vessel-related, particularly the vessels with the positive remodeling, SVGs, all the branch points, which Hazra was also talking about. It could be from MI related, like the late presentation, more the late. There is one paper, if somebody presents the STEMI syndrome beyond 4 hours, the benefit of primary PCI drops down dramatically. And shock syndromes, failed lysis, all they do bad as far as from the thrombus perspective. And PCA related, like your wire balloon stent, I'm going to show you a case of classical angry clot phenomena following a stent. And of course, platelet resistance, inadequate anticoagulation, and so-called HIT, heparin-induced thrombocytopenia. If you want me, or if you ask me to quantify, it grades from 0 to 5. 0 is no angiographic evidence for thrombus. 1 is angiographic haziness, which gives a suggestion of possible thrombus. From 2 to 4, there is definite thrombus, which could be from less than 50% of the vessel diameter to more than 50% of the vessel diameter. Now, more definite large thrombus, it will be more than 2 vessel diameter, and it is complete occlusion, the most higher grade. And this is another interesting, which we commonly see. I hope my other faculties will agree with this. There is a Epan colleague who have angiographic prediction of huge thrombus burden, large vessel, infracranial artery more than 4 mm, so-called a vessel with a positive remodeling, and abrupt cutoff. That again tells you are dealing with a huge thrombus and a persistent diastasis distal to the occlusion, and proximal to the occlusion there is a floating thrombus and an incomplete and obstruction with an angiographic thrombus with the greatest linear dimension, more than 3 times of the reference diameter, and accumulated thrombus well seen proximal to the occlusion. So floating thrombus, distal diastasis, abrupt cutoff, huge proximal thrombus burden, greater linear dimension, more than 3 times of the reference diameter, all speaks for an angiographically huge thrombus burden, where one would definitely need to deal the thrombus before putting the stent. And of course, the pharmacological way to deal will be both antiplatelets and anticoagulant. When it comes to antiplatelets, it's intravenous. Dr. NIL Johnson mentioned about IV cangrelor. It is a fast. You can just load it with your antiplatelets, and if cangrelor champion trial, if cangrelor on board, For some reasons, if it happens to be a case for a surgeon, you can recruit your platelets quickly so that you don't have an undue bleed when you open his chest. And of course, the 2B3A inhibitors, the role to play, and definitely if an ACS STEMI syndrome, definitely the data is now stronger for prasugrel and tika. Clearly, this slide has omitted clopidogrel, which I am agree. I think hopefully the other two speakers will agree for this. I think there is a caution, of course. Still, there is a role to play. Maybe if there is a clear-cut contraindication for both prasugrel and ticagrelor, maybe one can consider. Otherwise, the case is a strong case for either one of the two. And of course, anticoagulation, the data is stronger only for unfractured heparin rather than low mortar heparin. Regarding 2P3A, we know that there was a big honeymoon time with this molecule with interventional cardiologists, but once data came up that it dropped down to class 2A to 2B, it has become now in a bailout situation where you think the thrombus burden is huge, where you think there is a slow flow, no flow, just you give intracoronary bolus. That is how it is being used. Very rarely there is indication for upstream in a high-risk PCI like it is class 2B now. Upstream is class 2B and bailout intracoronary boluses are class 2A. And regarding heparin, I said it is still the EFH class 1A recommendation. IV enoxaparin is only class 2A. Of course, if there is definite evidence for acute heparin-based thrombocytopenia, the bivalirudin comes as a class 1 in this scenario. There was a time period, there was more use of bivalirudin, but I think that phased out. So now it is in primary PCI STEMI, it is EFH order of the day. Very rarely we use bivalirudin, particularly when you deal with the syndrome of, it may be meaningful in COVID era, but not in every STEMI case. And regarding devices to deal, that's the most interesting issue here. Thrombectomy devices could be manual aspiration device or mechanical thrombectomy device. And embolic protection devices, let me touch, much talked about, but no data. Regarding thrombectomy devices, we had a manual thrombus aspiration. I involved with the catheter from Kanagaba, it's a thrombus, called the thrombus aspiration catheter. Even though I don't do it routinely now, so it helps in selective cases. Mechanical thrombectomy devices, I don't have much clinical experience with any of those devices, which I'm going to discuss now. Regarding manual thrombus aspiration, it was suggested in May 1995 by David Arth. This routine thrombus aspiration was made popular by TAPAS trial. Somewhere around 1,071 patients were clearly told superiority, where I was in an era where I used to practice 24/7 primary PCI. Invariably, moment it is a STEMI syndrome, I invariably put an aspiration catheter. But later, when the total trial came and TASTE trial came, TASTE trial particularly, even though it was a neutral trial, there was no mortality benefit. But after the total trial, which is a huge trial, where there were more stroke incidences, then our interventional community moved from routine aspiration to selective aspiration. Now, it is like a 2B3A, how you are bailout selective. Similarly, in aspiration also, it has become selective bailout. But case to case with an experience, having understood the nuances behind. What is the nuance behind total? You need to keep your catheter not away from the coronary arterium. Don't miss your aspirated clots outside the coronary arterium to result in clot. And when you run your catheter, make sure you keep aspirating and running so that you don't cause it. So these are all, once you understand the nuances, you can still routine avoidance. But the message is clear that it is no more for routine aspiration. Regarding mechanical thrombectomy devices, there was a big news about rheolytic thrombectomy using angiojet, but by a Venturi phenomena, but with the Jetson study, it didn't show up any dramatic improvement. It caused hemolytic anemia and it caused bradycardia because of the adenosine release. And this is interesting. I think I'm looking for a day where I will be using this laser in a primary PCI scenario or in otherwise huge thrombus-laden artery. This is basically less energy, which energy generated acoustic shocks, which separate the thrombus from the vessel wall, dissolve and vaporize the clot. It also has an inhibitory effect on platelet aggregation, leading on to stunned platelet phenomena, supported by a caramel multicenter registry. Very appealing, 151 acute MI patients, 68% of them who had large thrombus burden. Following ELCA, STEMI grade was significantly increased with an improvement in angiographic stenosis too. And this is an exciser, another mechanical way of sucking out the clot. It consists of a helical cutter enclosed within a protective housing attached to a dual bore catheter shaft containing guide wire and vacuum extraction at the 2100 RPMs. It entraps, macerates, and extracts the thrombus in a vacuum bottle. Again, supported by a Zaman trial, 2,000 and odd patients, even though there was dramatic ST resolution at 60 minutes post-PCI, but at 30 days and 6 months, no grade cleavage. That's what happens with all this aspiration device or mechanical device. It takes care of the procedure on day one, but no great benefit. The meaning is here, it takes care of the epicardial coronaries, but we never understood what happens to the microcirculation because there is no ideal device which has prevented distal embolization. Let me take you through one of my case. 31-year-old smoker, young male, total occlusion, classical STEMI syndrome involving LAD. We did a thrombus aspiration because angiographically it is abrupt cutoff. You can see there is a large thrombus in the proximal vessel. There is a floating thrombus in the proximal vessel. So we thought it's worth aspirating the thrombus. There is some news from the other vessel too. It is not occlusive CAD, it is a thrombotic CAD. So we thought, what aspirating the thrombus? We did an aspiration. Then this is following aspiration, the vessel looking better now. ST is stable. There is no ongoing ischemia. Flow is better. Hemodynamics are better. So we just shifted him and called him back after a week in-house. He was kept in the hospital. Took him after 7 days for an OCT. VCT showed good MLA. Very minimal thrombus burden, no plaque rupture. It is preserved vessel with no plaque, kind of an erosion, typical of a 31-year-old male smoker. Pure thrombus, sucked out. OCT showing clean-looking vessel with no plaque burden at all, probably of plaque erosion. So stent deferred, doing well. And regarding the protection devices, various devices like distal protection device, filter wires, a proximal occlusion device. We got all this knowledge from Safina's vein graft intervention that out of the SAFER trial, we thought, will these devices, if it's applied in STEMI syndrome, there were various styles, emerald, asparagus, but unfortunately, even in SVT, apart from the SAFER trial, even though SAFER trial supported the use of a protection device, there was no much use from the interventional community. The cases where SCGs were done without protection device, also they did well. So even in that SVG intervention too, it is losing momentum. It needless to say, in STEMI already, it started off with weak data to support, so none of the protection device were dramatically made a dramatic turnaround. So when I want to discuss a stenting strategy, the options could be direct stenting, covered stenting, and deferral of stenting. And direct stenting definitely has an advantage in the form of quick procedure, less radiation, less contrast, and less distal embolization, no slow flow, no flow, because you quickly fix and come out. However, the disadvantage is long term. At 30 days and 1 year, the results were not comparable to conventional stenting. There is a chance for underestimation of the vessel size. You may not be able to do it directly in a tortuous calcified vessel. And the thrombus which was left behind the stent can cause a late resolution and the late acute malopposition and whatnot. So there were acute results were fantastic, but long term it got failed against conventional PCI. This is one case of inferior wall MI, 45-year-old female. You can see huge LCX, nicely branching out to 2 OMs. And The operator wanted to have a quick stenting in view of thrombus may get dislodged to the one of the volumes. So direct stenting was done. Post dilatation was done. Not a bad result. So probably in a larger vessel, he could size it better and deploy it well, and probably he is able to post dilate well. Should remain symptom free in long run too. So direct stenting is still an option in case to case basis. And the deferred stenting is definitely an option because it is a novel strategy, particularly when patient is very stable, particularly when there's a distal flow is established. This can be a time interval of from 24 to 48 hours where you can uptitrate your intravenous 2B3A as well as heparin, and subsequent angiography can reduce the thrombus burden. There is less risk of distal embolization. There is many meta-analysis clearly shown there is a greater improvement in long-term EF in the deferred group. It allows for better sizing of the lesion of the artery on subsequent days rather than, because in day one, it is a reaction of the artery to the thrombus in a vasospastic way, where it, with the better dealing of the thrombus, not only thrombus is taken care, the thrombus-induced spasm is also taken care. Now you are able to size the artery better. It could provide better appraisal of revascularization strategy, including avoiding an unnecessary, like in my first case where subsequently I could able to confidently avoid the stent. In STEMI case, repeated angiogram may allow treatment. It is not only that, the subsequent angiograms not only gives a chance to assess your culprit vessel, it also gives a chance to assess your non-culprit vessel also can equally. There may be an element of spasm in there too, which can give a different picture now. So differ study was one study which showed a positive result, but Dynamic 3 differ showed a negative result. At the end of the day, we have one study where differ as a focused population was recruited, whereas in Dynamic 3 differ, it was an unselected patient. So it is again up to the individual to take a call on this, when to differ, when to do direct stenting. And this is another case, a very interesting case. 38-year-old male came with STEMI syndrome, anterior wall. Definitely one would hesitate to put a stent. So this is OCT done during index admission, which showed better MLA, no evidence for plaque rupture. It is just a residual plaque or whatever you call it, a spontaneous residual, spontaneously cleared thrombus with the residual thrombus burden somewhere between 20 to 30. You can see here now, it is a thrombus, almost majority of thrombus. Behind the thrombus, of course, you cannot see what's happening. So we thought we'll differ. So 2 months down the time, we called him again intentionally. He was remaining symptom-free, but still we called him. Angiographically, it was looking even better. Again, we did an OCT. OCT was looking somewhat more better than the previous time. This is what the erosion trial was done by Chinese people at 1 month. There is a greater reduction in thrombus burden. The vessel was looking somewhat better. Of course, there were residual thrombus were there, but it looks like intact fibrous cap. We even did, I remember if I'm right, we did even a physiology in this vessel because we thought after 2 months, no more we called it the culprit, so why not? FFR was also negative. But look at it here, he stopped the medication. This is what happens. This is what Dr. Hazra was talking about. Sometimes by doing too much science, we give false assurance to the patient, whether the way we communicated to him made an impression. That's why the statement is very clear in acute coronary syndrome, whether it is STEMI or NSTEMI, irrespective of whether the vessel gets a stent or not, it's a dual antiplatelet for an ER. So probably the false reassurance, he stopped the drug and came with again same vessel, same culprit, same kind of a total solution. This time he was hemodynamically unstable, ongoing ischemia. Distal flow was not brisk enough to differ, so went ahead with the direct stenting, and there was some thrombus shift to the diagonal, but it's just a thrombus shift to the side branch. which we thought will improve. He was kept in ICU, and bottle of terifluban was given for both for the LAD as well as for the diagonal, whatever distal thrombus to be taken care. And regarding covered stent, I involved in ERA with the MGOD stent, which is a PTFE coated stent. It is a bare metal stent. Some challenges to track the stent, but not bad. But again, the restenosis was high. Being a bare metal, one can understand that. Then Roxana Mehran Poplar, this stent is, which is again one of the few self-expanding stent available in coronaries. Another one was the dedicated access stent, dedicated bifurcation stent. Apart from that, this is only a self-expanding nitinol stent, which is recorded was available in recorded form. Of course, the opposition 1 trial was supportive, but subsequent trial, the opposition 5 came, couldn't satisfy the non-inferiority. So I think stent is, I think Dr. NIL Johnson will tell us what's happening with stent is, what can happen with stent is near future, because still I am very much convinced with this design. The days when pre-pandemic, when I was TCT, there were big talk on this stent is just platform. And this is another case, 53-year-old male came with inferior MI. You can appreciate in RCA there is a haziness suggestive of almost grade 3, 0, 1, yeah, it's almost 2, grade 2 to 3 thrombus. It is occupying 50% of the vessel diameter, so grade 2 to 3 thrombus. And when they did an OCT, they felt the MLA is compromised. There is some areas of plaque rupture too, so they thought they can fix the artery. They had some justification from imaging to fix the artery. Let's see here what happens. This is what I am calling it as an angry clot syndrome. Moment it was stented, you can see now there is a distal embolization, no flow. There is a propagation of thrombus to the proximal RCA2. Entire artery is now clogged. This we call it as angry clot syndrome. Then the operator promptly given intracoronary lytic. This is all one area where intracoronary lytic can be helpful, reasonably taken care. Very little residual thrombus just in the proximal RCA. Patient was left in ICU for terifluban. And so the whole lot, when you want to approach a thrombus in coronary, it is basically to prevent the propagation and distal embolization. The key is here antiplatelets and anticoagulants. From the antiplatelets, it will be always higher antiplatelets like Prostacyclin and Ticagrelor. When it comes to anticoagulant, of course, IV cangrelor has a role to play, TB3 inhibitors, and of course, EFH is the bottom line. When it comes to intervention, if the distal flow is no, you need to naturally wire it and establish the flow. Depending on the result, you can proceed with balloon and stent. If you think there is a thrombus small, still you can go ahead and fix it. If you think it is a large thrombus and still, in spite of large thrombus, giving impediment to intervene, but if there is an ongoing ischemia and evidences for disturbed hemodynamics, one need to go ahead and fix it, like by thrombectomy or laser aspiration thrombectomy, one need to fix it. For some reasons, with a large thrombus, if there is no evidence for ongoing ischemia and patient is hemodynamically stable, definitely one can defer the further PCI for 48 hours, and you can bring him back to the lab again on a different day. The thrombus may look better with the ICU uptitration of terifluban and anticoagulants and whatnot. And with this, let me conclude that thrombus is really a challenge, case to case, one to take a call on from drugs to device to a stenting strategy. Thank you, one and all.
Thank you, Siva. That was a very, very thought-provoking and quite elaborative talk, as expected from you. May I invite Dr. Johnson's comment here before we open up the session for Q&A. You know, this flow begets flow, thrombus begets thrombus. Yeah. So whatever method you want to apply in a thrombotic lesion, try to establish a flow. So once you get a flow, then you can think about imaging, stent optimizations, post-dilatation, etc. So when the pressures are down, you keep it up with your MCAs or your your inotropes. So what I'm saying that even you do not see a good distal bed, once you're sure that the wire is in the distal bed, put a stent. Do not defer it. And he has rightly mentioned the stent is the solution for STEMI and a thrombus. Sometimes you do not see the distal flow. You can take a small microcatheter or ruptured balloon in the distal bed. You inject a 2cc syringe to know the distal zone. But imaging also is helping us to choose the right size of the stent, right length of the stent. I was expecting ACR from your OCT so that we can pinpoint the exact your co-registration of the culprit plaque. So that is also another feature. And ACR of your IVA secretions, ACR of IFR, needs spectroscopy, like knowing the lipid content of the plaque also is also coming up in a big way. And there are methods where you can apply both ultrasound and need spectroscopy. And you know the NCLBI. So these vulnerable plaque demonstrations, what you have shown, fantastic. The MINOCAs, INOCAs, having an imaging like a thrombus you clear by a microcatheter, you see a pristine artery without any plaque rupture or any cavity, without any nodule. You can send them on medical therapy without any stent at 32 years. We do see these kind of cases in India because of smoking, marijuana, the energy drink, different kind of addictions, heroines. COVID is another issue. Johnson must have seen those things. With that note, I would like to invite Dr. NIL Johnson's comment.
Yeah, thank you. Those are some fantastic cases, and they really got me thinking about some of my own thrombus disasters over the years, because I was particularly reminded of that right coronary artery where the operators started doing some ballooning and just it all went downstream, and you've turned something that is relatively stable into a bit of a disaster. And I really like your note that when you're able to see that there is flow and that there's not some kind of active ischemia that's ongoing, it's very reasonable to put patients on a 2B3A inhibitor for several days and then come back and take a look at the vessel again. In some ways, what I've seen from the data like the deferred trial and some of the other deferred PCI trials is that it's taught me that if you can reestablish flow and you have a relatively large lumen, you've got time to figure out when you need to stent, and that no reflow phenomena is something that certainly is going to be reduced over a couple of days if you want to wait. I've not been convinced that it's the right strategy for everybody. I think that some of the defer trials were done in the hopes that this would be a very widespread strategy in STEMI. So I use it selectively in cases where there is a large thrombus burden, try to reestablish flow, or flow is already reestablished, sit on it for a period of time. And as you point out, what you'll see is that the thrombus will clear up, your imaging will be able to see the walls, and you'll make a much better choice about stent sizing. And I was particularly intrigued by the young 31-year-old gentleman who was the smoker, who then you cleaned up on a 2B3 inhibitor, the thrombus burden really went down, you put him on dual antiplatelet therapy, and then I guess he was so excited because things got better, he stopped it and had another episode. What do you think his underlying mechanism is? Do you think that he has maybe some hypercoagulable state coupled with some exposed, as you say, erosion in the vessel? Like it seems to me as if there must be a couple different things going on in him to trigger that.
That was really, I was also thinking about that case, even though you, of course, if he is a drug defaulter, if I have put a stent on day one, it would have been a definitely bad scenario. But even then, we deferred stents for definitely the spontaneous MI is better to deal than MI out of stent thrombosis. Probably that's the reason he came with reasonable hemodynamics. It would have been a stent thrombosis, this presentation would have been malignant. But I feel imaging is a challenge in acute coronary syndrome, particularly when there is a residual thrombus. We still miss the cavities behind the thrombus. This particular fellow, I couldn't bring out, we did, I think we did OCT even when we did the PCI too. I think there was plaque rupture. We don't know whether it is a incomplete healing of the earlier one or a new plaque rupture. We don't know. That is why there are a group, even though MLA is good, if there is a cavity behind, that is, I mean, plaque rupture with the cavity, they still go ahead. The Japanese group, the Kubo et al. Group, they still go ahead and fix it. They differ only in an erosion group. I think whether to leave these small cavities for high intensity statin or evolocumab or inclisiran kind of a stuff, or stent as well as challenge with these drugs is definitely another day to debate. But I think if there is a plaque rupture, I feel in this particular case, it was a missed plaque rupture behind the thrombus, which was not delineated by the OCT, probably with the drug default invited in another syndrome. I think both of you right in telling that differing, even though the data for deferral is looking promising, but in a given day, all the interventional cardiologists want to finish off, try to offer the stent to their best. I think it has to be practiced very selectively in a very huge thrombus burden. Where do you think it is not a question of distal embolization alone? It is going to give challenge to assess your vessel too. Then definitely it's a worth the call. And another interesting news about this deferral stent is, as rightly mentioned by hazra. Before taking the call on deferral, take your microcatheter or your thrombus aspiration catheter all the way down, and you may see a distal bed now. Now you can just stent and plaster the thrombus against the wall. So thrombus to thrombus stent. And this ACR suggestion by Dr. Azra, I think when he visited our lab, we showed one beautiful RCA where we could able to land with an ACR guidance covering all the vulnerable part of the plaque. In the middle of the lesion, there was a plaque rupture. So definitely this ACR, whether it is high definition IVS or OCT with angioco-registration, particularly in a STEMI syndrome, where at the edges, if there is a lipid-rich plaque with a thin cap, definitely we are going to invite on table or on following days edge dissections and stent occlusions. I think one can avoid that. There's a question here, how one can do a thrombus aspiration. I think my suggestion will be always use, don't try to look for money here, try to use your new catheter because that's the key here. And take it, well, keep your guide well engaged. It just, the moment it reaches the proximal to the clot, start sucking in. In a sucking mode, then travel inside very, very slowly. It's another question of traveling the thrombus. You need to travel the thrombus by clearing the thrombus. Go slowly, keep coming out. Don't come out all the way out of the guide. Then again, disconnect the syringe, connect it again, keep sucking it again. Go slow, come out slow. So definitely you will aspirate clot and don't inject. There may be left clot within the guide. Now if you inject, those bits will go inside. Allow the back bleed nicely so that you are taken care. That's what the message we have got out of total trial. Those left out bits went into the coronaries or into the carotid, which made those that trial made into the selective. Still, you can operate in more cases if you understand the nuances of this thrombus aspiration device. And there is a question for the Razra. If you have a TIMI 1 or 2 flow down the artery, would you put a stent or defer a stent? I think already you have an answer. I will go and study the distal bed. Depending on the distal bed, you will take a call on this. I think almost we have done. It is 8:35. I think thanks once again, Dr. NIL Johnson. You have, the debate was really fantastic. This is the first time out of all the 4 leagues we had more discussion than debate. And Dr. Hazra, even though he made it his talk so aggressive, he said, I am for complete. I think everybody here, that's the passion of interventional cardiology. That's why we have grown in three decades from, I think the regulating stent came in 2000. Now it is 25 years down the line, we have able to conquer many frontiers in coronaries. Probably this aggression was there with a whole lot of community. With this note, I thank once again Dr. NIL Johnson from USA and Dr. Hazra from India to be on this wonderful talk. Thank you, one and all. Thanks for all the delegates.
Thank you, everybody.